So hello to the viewers. I think we are live now. Please let me know in the comment section if our audio, video, everything is perfect. Okay, Salman, good evening. Raj. So I think people have joined. We'll just start in a couple of minutes. Okay. All right. So we'll start off. Good evening, Puneet. So good evening, everyone. I am Dr. Rahul Rajeev. I am faculty of NEET PG and NEET SS Medicine in DocTutorials. So I am a physician and a neurologist. And with me, I have an eminent panel of super specialists. So we all will be guiding you on today's topic, that is the approach to general medicine residency. Now, in this session, there are few issues that we are going to address to the students. So number one, the NEET PG results have just been announced, and many of you will be having doubts on which branch to choose. Some may be already interested in medicine. Some are having doubts, medicine versus radio or medicine versus, say, pediatrics. So we'll help you with those few questions. We'll discuss on the pros and cons of the medicine branch. Obviously, many of you will be having a doubt on MD versus DNB. Should I take MD medicine from a private peripheral college, or should I take DNB medicine from a good college? You will be having doubts on, is medicine the right specialty for me? So how much should I read in medicine? What about clinical skills? What are the books that I should read? What are the online resources that I have? And obviously, since we all are a panel of super specialists, I am a neurologist, so we have every branch super specialist in this panel. So obviously, there will be one question: is super specialty mandatory after your MD or DNB medicine? And also, you might have a query like, I'm joining MD medicine. At what point of time do I decide, okay, this is probably the branch that I want to choose for my super specialty? So this is what the meeting will be addressing on. And first of all, I welcome all the guests of this panel, and I'm sure that this session will be definitely an enlightening one to the viewers. So let me start off with some introductory comments. If you are thinking of taking medicine for your residency, I should start off saying that you have made a very good decision, because medicine is a branch where you will have that love or the interest for seeing patients, working up patients, managing cases. I think this is one branch where you have, or which requires you to have a perfect combination of clinical skills and extensive reading, of course. And remember the famous quote from William Osler. See, when you go to your medicine residency and you start off, always remember, it's not just about books and reading, and it's not just about seeing patients without reading anything. That's where you have the famous quote from William Osler. And I would always suggest all of you that there has to be a perfect balance. You've got to see patients, spend time. At the same time, you have got to read as well. Reading alone won't work. Seeing patients alone without any reading also is not the best thing to do. So with that, let me start off, and just we'll take the questions as well from the chat box. So obviously we will address those issues as well. So let's start off. And yes, so any doubts, any queries that you have, please type in the chat box. Okay. Okay, now while the questions start coming in, let me just give you an outline of the residency. Okay, so Harshad is asking what books to read for medicine. Now, let's first, because you are going to be a medicine resident, let's first focus on the first year of residency. When you join first year of residency, obviously, you are going to be encountered with a number of cases, a new environment, a new working environment, because so far you have been mostly a student, but now I think it is the beginning of transformation to a professional. And when you start off the first year of residency, remember, it's not like, okay, I start reading Harrison from page 1. It's not like that. It always goes in a case-based manner. So for Harshad, your question, in first year of residency, be punctual and be sincere in your wards, in your ward work. And I think learning in the first year of residency is based on the cases that you see and work up in your wards. It's not like you are in the wards, come back and start reading respiratory system from page 1. No. Suppose you encounter a case of pleural effusion. Suppose you encounter a case of pneumothorax. You want to know more about the current management guidelines of the pneumothorax. You want to read about it. So what does the guideline say? Now, so your learning in first year of residency has to be in a patient-centric way. So let me just invite to begin with Hemant sir. Hemant sir, good evening. So,
good evening, sir.
Good evening.
Hello, students. I'm Dr. Hemant Kumar. I'm the faculty for medical oncology at DocTutorials. I still remember my days of...
the question I want to ask you is the same one. The question that Harshad asked. What about learning in the first year of residency? Your intake on that.
Right. That's what. It is a very important question. I just remember my days when I entered my MD medicine, and just the second day of my MD medicine, I was thrown to the casualty, and you suddenly have a sheer load of cases. One probably is organ of phosphorus poisoning, CA'd with hepatic encephalopathy. You have acute MI that comes in. So it becomes difficult, and what you're probably going to do. The most important thing is what I was doing that at least I go back that day, what cases I've seen. Say probably I've seen a case with hyponatremia. I'd just probably go through the algorithm of how I evaluate for hyponatremia. Patient with acute MI, what are the possible ECG changes in MI? Half an hour daily is a must. I know residency days are busy. Sometimes to pick up half an hour for even food is difficult. But in case you just inculcate this half an hour daily reading of the basic thing that you have seen, And the best way to remember anything is what you have seen that day, and you go back. Next day, you come back and you apply the same thing. Once that happens, and probably in a month or two, you make this a habit. To be frank, even now, I try to come back and every day try to read half an hour of something that I have seen today. And that makes a big difference. And it is not only during your residency, but this is something that you need to carry on. First year, definitely no big books, nothing. I had Washington manual in my pocket throughout. Case comes, DK, probably I just open and see what best thing I can do. And it's only over time you learn. You end up doing mistakes, learn from your mistakes, and never be afraid of asking someone for help. That is, again, once your first year, you're always treated like a junior. But that current era has changed. It's not like probably the previous days where your seniors would be really seniors as such. Probably they are your colleagues and they are going to be your mentors. So ask for help when you don't know. Nobody will try and say, because if you're dedicated and you're going to work in the field, everybody is willing to lend a help. And definitely we are, all of us are here as well, probably going through the MD residency with you as well.
Yes, thanks a lot, sir, for your inputs. And I want to tell all the residents as well that in the first year of residency, your consultants are going to assess you not just based on the quantum of theory knowledge that you have. So probably they are not going to assess a very good resident by whether or not you know the gene mutation of a beta myosin heavy chain in a hypertrophic cardiomyopathy. It's not like that. So I think two words most important in the first year of residency is dedication and sincerity. So you've got to earn that name of a dependable resident or a trustworthy resident. And I have seen some of the residents, maybe first year residents, telling me, sir, first year is a lot of hard work. I keep on writing discharges. So I feel, am I a clerical person? But I have got to make a very important point here. I think, see, writing discharges are also a part of your training. This is very important because a common misconception is, that is just a clerical work. No, because see, once you pass out as a, say, MD medicine person and you start practicing, suppose you admit one patient and then, you discharge the patient. So see, the clinician you are, the doctor you are, the physician you are, is often judged by another doctor seeing your discharge summary. The way you write your diagnosis, the way you write how the case was worked up. I'll just tell you a simple example. So I have seen discharge summaries where, say, an MD medicine person has written a diagnosis just like stroke, okay, stroke right hemiplegia, something like that. They often forget that when you write a diagnosis, three components are important. Number one, you've got to write the functional deficit of the patient. That forms the first line, functional deficit. Number two, what is the anatomical site of lesion? And number three is the etiologic diagnosis. So rather than making a vague statement, you writing the etiology stroke, I think it's very important to write a proper structured diagnosis. Now that actually gives the impression to a second doctor. Suppose I refer a case to another doctor, okay? So he assesses me, he has not seen me, he assesses me seeing my discharge. So writing discharges, writing the diagnosis in the discharge summary, writing how the patient was evaluated, I think is a very, very important part of your training. Okay, all right. So that is one point I want to tell you. Now let me just, okay. So this is a question that Dr. Nandini is asking. So I'll put this question to, say, Dr. Vivek. Dr. Vivek, have you joined? Yes. Okay, I think Dr. Vivek has not joined.
Yes, sir. I would like to answer it in some time, sir. If you could please pass this question on to someone else, sir.
Yeah. I think he is probably, Dr. Vivek is in the hospital. He is on the way back. So I'll ask this question to Dr. Karthik. Dr. Karthik, something that Dr. Nandini wants to know is, she really loves medicine, but she does not want to get into another rat race for DM, which has become a compulsion, and hence I am leaning towards PDR. So basically, her query is that she likes medicine, which I think probably is her first liking as well, but she has a doubt whether this compulsion of going to super specialty. So just what is your opinion, sir, on going for a super specialty post your MD? Is it necessary? And can you just help her with that query?
Yeah, thank you for the question, Dr. Rahul, sir. And actually, when I got into my medicine residency some years back, I was initially planning to stay as a medicine faculty after finishing my residency, because I wanted to stay in medicine and I didn't want to focus my entire clinical sense into one subject so as to narrow it down. I want to see a broad range of cases. So that was my initial intention on joining medicine residency, and that would be the thing in your mind for many of the candidates. But what happened is that as I went through more and more cases, you become interested in one of the subjects. And for my case, it was endocrinology, because for those people who think that super specialty is a necessity, I don't think so, because what one of my teachers is that used to tell me that is that you want to, so general medicine is actually the core thing, and what the cardiology is, what the nephrology is, what the hematology is, those are just subspecialties. It is not a mandatory thing that you should do a super specialty for getting a good job. There is enough demand in the market or enough demand in the hospitals for a good physician, because physician is, even though there are a rising number of super specialists across the India, but physician is often the first window where the patient is seen, and only when the level of expertise goes beyond, or you have to encounter a rather complicated or rather a difficult case, and that then only will the case be referred to a specialist. So I don't think that it is always mandatory for a person to go for a super specialty. So that I think, Dr. Nandini, that should not deter you from choosing medicine, because medicine, pediatrics, every such specialty has got its own charm. And one message I want to give to you is that if you are really interested in seeing adult patients, seeing the varied clinical presentation of different cases, that the one thing that you should go for super specialty is a mandatory thing, should not stop you from taking medicine.
I think I completely agree with Dr. Karthik here. Now, this is a common misconception. I've seen students talking about this in various social media platforms as well. If you take medicine, super specialty is compulsory. And students talk among themselves that only if you take super specialty will you get a job. There is nothing like that. As Dr. Karthik said, there is enough opportunities for MD medicine person also. And if you want to stay as physician, you can very well do that. Because I am sure that you are not going to encounter a corporate hospital where there is only a team of super specialists and there is no physician. As Dr. Karthik said, the first window is often a physician. So if you want to become a competent, good physician, you can very well do that. It's only that there is some sort of a peer pressure. Okay, everyone is going for super specialty, I should also go. Well, if you take medicine residency and by the time you reach your, say, the second year of your residency, and if you feel, okay, I have an inclination towards pulmonology or I have an inclination towards cardiology, then you can change. As Dr. Karthik said, even for me also, when I started off with medicine, I just wanted to remain as a physician. But eventually, as the medicine residency goes on, you get all the super specialty postings, your thought process might change. You might have an inclination towards certain branches. So I would suggest that Nandini definitely take medicine, go with an open mind. Even if you want at the end of residency to remain a physician, That's very good. No problem. At the same time, if you have a perspective change, no, I just want to go to the super specialty. I like nephrology. Then you can very well do that. Okay. All right. So yes. So Vijay sir, any points on the same?
Yes, sir. I might be able to answer the question even more because I did pediatrics then into DM medical oncology. So just that doing pediatrics is no more an end specialty. It is all interest driven and what you want to become as you do the MD pediatrics or MD medicine, you get into some kind of a like towards a single branch. That is when you want to do some particular subject. So it all develops over a period of time. So we can never say that we don't want DM just because there is a competition again and I will not be able to do the competition again. So it all happens over this period of next 3 years when they do the residency.
Yeah. All right. So let's. Victor has a question. Victor, it is a genuine question. Victor likes medicine, and Nia sir, he's asking the lifestyle of a person who has taken medicine. I like medicine, but I need to chill and have a calm life. So that is also a very important question because see, it's not just about your professional life, it's about your personal life as well. So Nia sir would just tell his opinions on the life of a physician, a resident first, and then once he starts practicing, the life, yeah.
Yeah. So it's a difficult question. Like, so we all have done residency. So chilling is not something that you're going to be doing in the first year at least. Okay, so the first year, if you're expecting chill, that is not likely to happen because it's a very hectic kind of job in the first semester. You have to learn a lot of things. There are a lot of jobs to be done. Whatever be the college, the first year is going to be slightly difficult for you, but your seniors will be there. There are you have to have your own peer groups. Okay, so you have your work. It is for sure. It may extend to late hours at night. But at the end of the duty, you should have a group to chill out with. Definitely, you can go to the nearby. I mean, we like Rahul, we all did from the same college. We have our own hangout places inside the college and the surroundings. So you should have ways through which you should be able to let out that pressure. That pressure will definitely be there, but there will definitely ways to, vent it out. And obviously, your seniors will help. Again, I have my own senior also in this panel. So your seniors will definitely take you to those treats or something like that occurs after the end of your posting and so on. So there are things to chill out definitely, but for the first year it is going to be slightly difficult, but that definitely you will overcome. Second year, definitely is going to be more cool. You'll be posted in the peripheries and departments like super specialties where you'll be treated as juniors, but they'll be teaching you. You'll get more of a free time usually, and you'll get time to study as well. Third year, definitely you have the exam stress. Okay, less of clinical works, but more of the exam stress. But again, if you are in a group, form a group of your own friends, form a study groups, study your practicals together. Even that is something that will give you memories in life. It's something I still remember doing, preparing for our practical with all our friends. So that is also something that can stay in your mind for a long time. So once you finish it, I'm going to your practice as a physician. Definitely it depends upon the setting that you're working. Every job has its own pressure. There will be demand that is expected from you. But again, as I am working, if you ask me if you have finished my MD initially, and I was working in a medical college kind of setup. So there I used to teach students what do you want to do. I could teach students. I love teaching. I could teach students. Then I was also practicing as a clinician as well. So I could get definitely it's up to you to decide what kind of a work you want. You can definitely fix your work timing, not maybe initial part of your career, but within a few years you will be able to fix your timings, and then you will be able to to maintain what is called as work-life balance. Okay, so that doesn't mean you have to do a super specialty to reach that level. You decide. You can have your own decision definitely and decide that this is the time that I'm going to work. And as I told you, it may not work in the first part of your career. It will take some time. Once you're established kind of a physician, you can dictate your terms. And then definitely there are things other than medicine also to be taught, like done in your life, as you said, to chill out, be with your family. Definitely you will get time. We are all getting time for that. So don't worry about that. You can definitely chill.
Yeah, I completely agree with Nia, sir. I think during your residency, it's very important that, see, initial few months, you may have some adjustment issues, but I think definitely with the help of seniors. In fact, I was fortunate to have good seniors. Nia sir is my senior when I was the first year resident, sir was final year. So actually, let me tell you one point. During your residency, you learn from your seniors, first of all. That's what I strongly believe. So they are your teachers to begin with. Yes, you have the consultants, but to have helpful seniors who help you, guide you, and I think it's the bond that you share with your seniors. So you see, we are several years post our residency and we are still in touch also. So I think, see, yes, in the initial couple of years, you might find it tough, but still you will get time to chill out. It's not like we medicine people are all boring people. We are super enthusiastic and super chill. Okay, so don't worry about that. All right. And I think, Kamal sir, do you want to take that question? You wanted to say something, sir?
Yeah, I was a very interesting question.
Kamal sir is a senior consultant cardiologist. Sir is the cardiology faculty in DocTutorials as well. Yeah. Yes, sir.
Yeah. Hi. Good evening, everyone. I'm Dr. Kamal Sharma, and I'm faculty for NEET SS for cardiology. Yeah. So very interesting discussion and very interesting questions that have been going through. I must say, and the generation next is actually pretty clear as to what they want. So just wanted to chip in with a couple of things. One, I think I've seen cardiologists who live a very chilling life and work 9 to 5. And I've seen guys who are doing infectious disease practicing and they are working 24/7 by 365. So it's very much a personalized choice, which at the end of the day, you would be able to make in your life as you practice. So don't be worried. I often say this, that choosing a branch is like choosing your life partner. You may end up choosing a life partner who is fair, not fair, rich, not rich, but ultimately what will matter is how much you love her. So if you love a branch, just go with it. I mean, it's not going to come in your way. Your love for the passion for the branch is going to keep you driving in all the senses, whether be it for money, for work, for satisfaction, for rise in career. Unless you'll not love your branch, I don't think you're going to be happy. And if you're not going to be happy, you're not going to pursue it to the fullest of your potential. And just one more point about pediatrics versus medicine, which you were discussing. I think we must also understand that it's a fallacy, as Dr. Rahul very clearly mentioned, that once you have done pediatrics and that's the end of the day. No, now you have pediatric endocrinologists, pediatric cardiologists, pediatric neurologists, even pediatric orthopedicians. So no branch is going to be end in itself. And even if you assume that you've done cardiology, now you have structural cardiology, you have pediatric cardiology, you have electrophysiology. I think the limit is how you yourself visualize it. So if you like a branch, if you like medicine, go for it, take it. Because I always tell my students, choosing medicine versus a surgical branch is, when your car gets out of order, you open up the bonnet and find out what the problem is. That's a surgeon. Without doing that, if you just knock on the top of the bonnet and you know where the defect is, that's medicine. That's on the lighter side. But that's the fun of medicine. You have algorithms, you have clicks, you see a patient with breathlessness and you see he's cold, calmly perspiring. You just don't have to auscultate. You say, this is heart failure. You find a patient whose heart rate is 80, saturation is 85, and he's not cold, calm. His blood pressure is 150. This is COPD. So those algorithm developments often happen only in medicine. And that's why the fun of medicine, I started off and I was like, if I get cardiology, I'll do. Otherwise, I'm going to stick around with medicine. And then cardiology happened and I'm there. So I think I just endorse all the points that previous speakers have given. And that's the comment that I wanted to make. Thank you.
So I'll take a question from Dr. Salman. So Salman wants to know about DNB versus MD medicine. I'm sure that a good number of candidates listening to this wants to know about this query. So let me just make a quick comparison of an MD DNB. See, there are pros and cons with DNB. So let me just discuss about the cons of DNB. Okay. So, but let me make a first statement that, see, there is not a significant difference. Obviously, there is a slight difference, but not a very significant difference. That is my first statement. But I'll just go through the pros and cons. See, first of all, majority of the DNB institutes are run in corporate hospitals. So obviously, the consultants there are likely to be busy, and teaching might not be their primary interest. So there is a chance that academics might not be that good. At the same time, there are several DNB institutes where the academics is at par or even better than the MD. So if you select a good DNB institute, I think you can nullify that point on the quality of academics. That is number one. Number two, the point is, again, I saw in the chat box about the pass percentage. See, the differences for those candidates who do not know. See, after 3 years of your MD medicine, you write your theory as well as your practical examinations in the same college. That is, you write your practical examination in the same college that you gave your MD medicine. So obviously, you will have internal examiners as well as external examiners. So your internal examiner will know the work that you have done over the past 3 years. They'll know how committed you are. So there is a chance that they might actually give you some help, at least in major colleges, majority of the colleges, they actually give help. And so you are writing the practical exam in a familiar environment. Whereas in case of the DNB, the practical examination happens in a different college. So you are totally unaware. The time you join your DNB, you do not know where your final exam is going to be. Only at that time, the time you are going to give the exam, you will know, okay, this is the college where I am allotted my practical exam. So all your examiners will be total strangers to you. So a bit of unfamiliarity will be there. So that is one reason why the pass percentage is less. Second reason, obviously, the first point that I said, academics may be compromised at several colleges. So that is another point that I want to tell you. And regarding the next point is the fees. So likely that in majority of the corporate hospitals, fees is on the higher side. So that is also one point you have got to keep in mind. And also there is a public perception. So see, some public at least tend to believe that DNB is diploma. Please remember, DNB is not diploma. Okay, DNB is not diploma. But at least still a few years back, there was a prominent public perception like that. So that is also one factor why people don't favor DNB that much. Now, what is the problem is, see, if you ask me, sir, I want to take DNB medicine and I want to do only medicine, okay? And will it affect me in any sort if I take DNB medicine and then practice as a physician? Well, if your aim is private practice or practicing in a corporate hospital, this will not matter much because there is very slight difference between an MD and DNB there. The only difference comes when you are going to apply for a job of a teaching faculty in a government college. So when you want to join as a teaching faculty, then there are certain points that you should keep in mind. That is, see, there are certain criteria that the government of India has actually given. So it is there in the NMC website as well. So the point here is certain colleges where you have both MD and DNB like KEM, there, you can, it is almost equivalent. When you can definitely, in a college where you have both MD and DNB, which means you're taking DNB, but that college has an MD seat also. There, you need not, you are actually at par with somebody who has done MD medicine. Whereas if you are doing DNB from a college where you have, say, 100 to 500 bed hospital, then you will have to do 2 years of senior residency to be eligible for a teaching post. Similarly, if it is above 500 bed hospital, then again, the criteria is same as that of the MD one. And again, the criteria is more stringent if the number of beds are less than 100. So you can go through the website to see the criteria as well. So that is one thing. I think Kamal sir just wanted to raise a point, I think, on the MD versus DNB. Yes, sir, please.
Yeah, I completely endorse what Dr. Rahul Rajeev is saying. Just a couple of points. Somebody was asking about the pass percentage. It's a common belief that the pass percentage in DNB was poor, which was the case almost a decade back. For last 3 years in MD medicine, I've been an examiner both in DM and DNB across the universities. The pass percentage in DNBs have gone up drastically, almost matching universities now. So don't take the passing percentage as a criteria to choose. You may have other reasons to choose. And I sometimes feel that if you have a place where you're doing MD, but you don't have good teaching program, then better choose a DNB program, which has got a good training program. So it's not that you always would prefer to do MD over DNB. There will be some DNB institutes, as Dr. Rahul Rajeev mentioned, where probably the teaching programs may be good. And I feel that would actually train you to the clinical practice scenario. You don't have liberty of, sending across as many tests as you want in a private corporate setup, because there'll be limitations how you practice it. It's not like we remember protocols in medicine would be send whole LFTs, RFTs for everybody. And you in DNBs, you'll be end up, getting only creatinine and SGPT as a marker of RFT and LFT. So that is the other perspective that you may develop. If you're entering a private practice straight away, then it may be of more value. And I somehow feel that you should, if you're looking at not to do super specialty or looking to do a specialty at the place or an institute from where you're doing your PG, then make sure that that also gets some amount of weightage when you have to choose between the two.
Okay. Thank you, sir. And just to carry on, for the same question, extension of the same question, there was a question, okay, MD in private peripheral or DNB medicine. See, don't just take MD for the sake of it. Please inquire about the hospital that or college that you're talking of as the peripheral hospital. There will be certain colleges where they're offering MD, but they have very less patient intake. Maybe the ICU facilities are not at all good, and the training is also not good. So just because you will get an MD degree doesn't make, okay, I want to somehow take an MD. No, it's not like that. So I have already listed the cones of DNB. So just match with that. So if you are taking a peripheral hospital, as you said, but just inquire. And this is one point I want to tell you. See, when you inquire about a college, there are points that you should inquire. Number one, what is the strength of what are the number of faculties in the department? Number one. Number two, what is the daily OP? Number two, what is approximately the daily IP? Number four, what about the ICU setup? Number five, what about the emergency setup? Number six, what about the other specialties? So, and then, comes academics, definitely, yes. And also the training, all this is actually important. But please ask this. And when you inquire about this to such colleges, always ask a candidate who is doing MD in that college. Just because someone has done MD from that college 8 years back, well, his perspective might be the training that he underwent. A lot of things might have been changed with regards to infrastructure, faculties, training. So it's better to have a first-hand knowledge from the resident who is doing there. And remember, this is my personal perspective. I just take the opinion of other faculties as well. Never ask the opinion about a college to a first-year resident. Why? Because you call him, you ask him how is this college. He would have been finished with all the hectic work that day. He is the one who bears the brunt of the workload in that hospital. So I think he's not the ideal person to ask, because obviously it has to be someone second year or third year, because he has a better understanding not only of the workload, about the academics as well. Because I've already told you, first year is mainly about work. So don't just call, a first year resident and ask him how is academics, are you getting time to read, what all books are you reading? Well, he might not at least get enough time to speak to his dear and now loved one. So that is not the ideal question you should be asking to a first-year resident. Not only will that demoralize you, you will be demoralizing the first-year resident as well, who is continuously working. Okay, so that point is there. So one question I want to ask Shinto sir, this is a question that is commonly asked. Sir, at what point of time, because definitely to begin with, everybody wants to know, I want to take super specialty. Sir, when is the ideal time that you decide, okay, this is probably the super specialty that I want to do? So your intake on choosing the super specialty, the right time, your right branch, and when did you feel, okay, sir, hematology is the branch for you because you have done your DM in clinical hematology?
Yeah. Sorry. So Dr. Rahul, friends, good evening. So I'll take on this question as, like, I think two kinds of students are there, for me at least. Those who are very passionate about medicine. So they do medicine and then they acquire their whatever specialty later on. And I do know a few of my juniors also. I don't know whether Nias was my first year. So the day one guy, my junior, comes and asks me, okay, sir, I want to go for DM endocrinology. So how is the time schedule? And I just want to prepare. So 3 years he has to get through and medicine degree, and then endocrinology is his final destination. Okay. So probably that is the wrong way to do it. Okay. So just like my colleague mentioned, it's like marrying someone. Okay, you have to get to know the specialty first. So other than that's the best way to do it, is to do the medicine in proper, because most of the colleges they have rotation, especially in the second year. Right? First year is basically you are coming out of the books, right? So you are handed over the cases. So you learn from, I think, three basic levels. One is, first and foremost, is the patient. So the patient will teach you the subject, plus how to handle the time, the stress, everything about the clinical medicine. So first and foremost is the patient. Second is your colleagues, your classmates. So where you have to balance that's where you get your your future professional dealings, etiquettes. That's you get from how you deal with your friends and your colleagues. Third is your seniors, right? So you gain your super speciality, that vibe you get from your seniors and your teachers. Okay, see, those who teach you, that's the third category. So what I got from my teacher, Nias will be knowing, and you also knowing, I don't know, you know PK Shashin, right? He was a hematologist basically. By manner, he's a hematologist. So I went with a blank slate, right? I want to just learn medicine, clinical skills. So the all three levels have helped me a lot. So my basic acquisition to hematology started in the second year. There were some quiz programs, and second year we get to know this rotations. I get to know other specialties also. So it was a close match between neurology and hematology. Okay, these two will be my close call, right? So when we started reading Harrison, there's a say that there is a H band, like the M band, the Harrison will have an H band because your HOD is a hematologist. So you are supposed to read that band. So your Harrison will get an H band at the end of your, by the time you go for the finals, there's an H band. So I had a strong H band. Okay, so that's when I decided yes. So the way the CBC was interpreted, I thought the hemat was a direct extension of medicine. So every specialty will say, okay, this is the direct extension of medicine, clinical medicine. For me, it was hematology. So I took it from there. So hemat, that time everybody said, okay, hemat, man, there were, I think, 11 seats across India, all over. But okay, so less people will be writing. So, but when you go there, you see like a bunch of people like hemat. That time you have to fly to every institute. So whenever you go there, there's a bunch of people outside the theory exam that will be sticked outside the whatever STPJ aims and all. So then, oh man, the 12 seats, the whole India have come to. So what will be neurology, nephrology and all? Like there'll be hundreds and thousands, right? So 11 seats. So from there, I thought, okay, we'll try for hematology because that was the passion. So passion should come later rather than you fix the specialty. Because I have many friends who have, I will take hematology, but when they work in hematology for 1 or 2 months, they just run away, right? So my juniors did that because the pressure they couldn't handle, because hemat is not like, it could be from anemia to stem cell transplant. Okay. But MD, before getting into MD, I joined PJ Chandi's surgery. So 3 times in a row, I got surgery. So I said, okay, I will take medicine, because surgery, they have to do surgeries in the middle of the night. Why should I take all this? Then I landed up in transplants. Now I think surgeon is better than me. At least there are surgeons who operate only in the daytime. So you can take hemat to various levels, from starting from benign to, you can practice benign only, you can take it up to transplants. So that's a matter of fascination you develop during your, especially during your specialty days. So that's I concur with my colleagues that pediatrics is nowadays not an end specialty. Many of my hematology colleagues are from pediatric background, MD pediatrics, DM hematology. And even nowadays, pathology, DM pathology, meaning MD pathologists can also write hematology. So it's never an end for specialization, I believe.
Thanks a lot, sir, for your inputs. Now, another very valid question in the chat box on this is again about settling down. So what are the insights whether to settle down in the districts or metros in terms of clinical loads? How do you get to decide on that? I'll take that question to Prashant Gandhi, sir.
Thank you. Am I audible?
Yes, sir, you're audible.
So this question, thank you. Basically, the student is trying to ask where to settle down after the MD or during the course, or what exactly is it trying to?
After MD, like see if the prospects may be on settling down, whether the metros or districts.
Yes.
So how to decide on?
Mm-hmm. Okay, this actually would base on the experience of the student beforehand. Like I have few of my friends. See, I am from Bangalore, right from my student days, school days, and then with my MD and DM was the first time I left Bangalore to CMC Vellore. That was my first experience of a long time. I had never left a metro city. Then in the 3 years I was there in Vellore, and it was more like, it was a different experience for me. For me it was something awesome. For me, the less traffic, the good air, and people are not in a hurry. That feeling was something which I felt is good. On the other hand, I know some students who are from periphery who always dream of a city, and they would want to do in a city, and they will do their MD courses, or at some stage of the time they would want to come to a city. But when it comes to settlement, it is more a question based on a very personal experience. See, suppose now I was there after my Vellore, I was again there in Chennai, and I moved now to a place called Warangal, which is close to Hyderabad. It is an upcoming city, more like a suburb. So here, see, I'm a gastroenterologist who is the first person in Warangal to have done endoscopic ultrasound. Okay, so that gave me an extra, that feel that yes, I'm doing something first time in this place. There are many firsts that I have started in this place. So had I gone back to a major city, I might have not gotten this opportunity. They in fact got me to this place because the hospital wanted to try something new for the population here, so that majority of the patients, actually from their perspective, their vision was many of the patients from this place are going to cities. So the hospital MD wanted to get advanced equipments to do those advanced things in this particular place. So that was his vision. It just matched mine, because mine was more like, I have to do the best for the patient who is coming to me, and if it is an advanced one, that would be great. So they got me there, and our vision matched. So on the other hand, I also have few of my friends who have moved down from peripherals to a city, and they're enjoying the life there in their format. See, for me, I had seen more of the city life, the metro, the busy life. Now, for the first time in Bangalore, when I go from airport to my home, it sometimes takes 3 to 4 hours. I would have actually traveled from city to city within 1 hour or 2 hours. But I have never thought or imagined that in 10 minutes, I can go from my house to the other end of the city and go to the hospital. I was unable to even think of those things. So now I'm actually enjoying this feeling where, the traffic is decongested, and, we get a different set of people, one set of people who are well educated and are trying to question us and see, and some set of patients come from complete villages who just come to get their best treatment, what they can afford. So this balance is something which we learn in due course, and I'm enjoying it. So if a student asks, sir, I want to settle down in a city or a periphery, what to choose? I would say it depends on your deep passion. You should have been in either places to really decide on what you really like and what you really enjoy in your life per se. Now, if you tell me the set of patients you may get in both the places are slightly maybe different. In a metro city, you may get patients predominantly looking at Google, reading through Google, making a diagnosis already, and will come and sit with you and ask you. Especially if you get functional disorders, you really have to get into psychology of the patient and get it out. If you have in a peripheral setup, you may not have this set of patients. You may have set of patients who just come because they would have tolerated enough, and they might come actually at an end stage, and you would actually see people at various stages of disorders, sepsis, MODS, not severe LV dysfunction, we getting to manage them. But in a city, I would have managed them lesser because majority of them initial stage only they would come. So there are major differences. It depends on the hospital, the load of patients you would want to know. And there are some of my friends who are from CMC Vellore who have done excellently good in their careers. And their mission is to go to a peripheral setup and help the remotest tribal people. So it's a passion. So I cannot think that how that guy is doing it, but he's passionate about his call. So if you ask me, it is total personal question. You should decide on whether what is your favorite spot. Is it a peripheral setup, or is it a tribal setup, or is it outside the country? I also know from the same institute who after MD has written USMLE and has gone to US also. So there are various options. You just have to hit the right string, and it may take some experience and talk to the people who have different experiences. If you want to go to a peripheral setup, talk to the consultants there who are already settled there. How is their lifestyle? How is it? What is a different thing that you want? Do you get time for your other passions? If you want, if there are some places where you may have to follow other passions, extracurricular activities, you would want to go on a night out somewhere. You have to know which place has this thing. So this question is a completely personal question based on your experience and your passion and your purpose in life. Like, whom do you want to serve? Service minds, or is it more of enjoying plus service? Lot of equations play a role. So this is my suggestion, sir. This is based on a personal experience.
I think I completely agree with you, sir. Whether you want to settle in a corporate or maybe in a district, all is your personal choice. What you want to be in life. I think many students ask or think like this: okay, only if you are in a metro will you be successful. See, your success is depend on what you define success as, not somebody else's definition. Okay, so if you are having peace of mind, a happy family, and if you are happy with your professional life, I think that is better off. Now I'll take two questions here. One question is by Afsal. Sir, the cure rate in neurology is low. Is cure rate in neurology low? I am interested in this branch, but I heard this. And a question from Neha. There is a reason why I want to take two questions together. Sir, many are saying DNB candidates are cracking super specialty than MD guys. Is it true? Please say, sir. See, whenever a NEET PG result comes, I think a group of candidates who are, I call it that MD CEOs, MD in confusing others. So it's like they make certain statements in certain WhatsApp groups. Don't take medicine. Don't take medicine. If you take medicine, your life, cut up, gone. Okay. Or maybe neurology. No, don't take neurology. No cure rate. So they are experts in confusing others. So please talk to people who are credible. It's not like, don't just depend on your friend for a solid opinion on this. Okay, should I take neurology? See, only a very minor fraction of cases in neurology are, not treatable. Think of stroke, think of myasthenia gravis, think of demyelinating disorders, think of seizures. So think of Parkinson's disease. There are lots of conditions where you have treatment options, where you can follow up the patient and you have that personal satisfaction. So Afzal, somebody who is an MD in confusing others has advised you, it's totally wrong. Okay. Every branch will have certain pros and cons. See, all of us are sitting in this panel and, we all are from different specialties. And look at all our faces, we all are smiling. So none of us is happy, unhappy about the branch that we have chosen. Okay, so Megha, your question also. Sir, many are saying DNB candidates. Again, MD in confusing others. It's the student you are, how you work and how you, want to go about your exam. That's the only thing that matters. And one question that has been asked in the comment section, I put that to Dr. Vivek Goel, who is a nephrologist. And he's someone I specifically asked him this question because he's always updated on everything that happens in nephrology. So you ask him something about some drug or any paper that was published yesterday, he'll tell you. So see, about the academics. So what books to learn? So the question specifically talked to Dr. Vivek is, Dr. Vivek, should you just rely on textbooks, and how important is sticking to the guidelines in general while you are doing your residency? Yes.
First of all, a very, very good evening to all of you, and I'm so sorry for being late. At the outset, I would just like to make a comment on the previous question. I'm so sorry. I cannot resist myself from making one at what Prashant sir also said. Very many questions that are coming up in the chat box and very many questions that are also filling our inboxes in the Facebook chat and elsewhere also, I find them very rhetorical. Students ask us, sir, should I choose an MD in a peripheral college or a DNB in a private college? Should I choose generals? I have got questions stating, should I choose general surgery or should I choose pediatrics? What I fail to understand is, see, these are all choices. And what I see life as, I might be sounding a bit philosophical, but actually life is nothing but a group of choices that you make. What choices you make, that makes your life. So, these are very personal things. I mean, very recently I saw a post that I think, if I'm not mistaken, rank 20 or 21 chose MD physiology. All India rank 20 or 21 chose physiology. And everybody was kind of judging her in a public platform. But I found that very, very secured of her and very, very confident of her to be doing so. I do not know her name, but I found that very, very secure of her because she is very, very sure of what she wants in life. So, rather than asking these questions to us or to anyone for that matter, it is time for you all that to introspect, to retrospect, to just halt for a moment and think what you want in life. See, again, there was a question on how to chill. I totally believe and I totally advocate. Maybe some of my seniors would not conform to me with that chilling is very, very important. And I am a nephrologist. I play cricket once a week. I play table tennis thrice a week. I watch every movie that releases out. I am teaching, I am studying, and I try to do everything. See, life is, it is only a one-time chance. So everything you want to do it. Why wait for it? So, I always tell the medicine residents also that, our life is a bit different. If your friend is an engineer, he would have planned his life in a very, very temporal and algorithmic manner, that he would study till 22, then he would marry, then he would have a kid, then he would probably buy a home. But, we are still studying. I'm 31 plus and I'm still studying. So, this is the way so we have to concurrently and simultaneously keep doing things. So when you are a medicine resident, study also, play also, enjoy also. If you want, have a relationship also, you've got to do everything simultaneously. Now, coming to what sir asked me, I mean, with due respect, we all know that when we are medicine residents, Harrison's is our Bible. Harrison's is our Bhagavad Gita. And that is the book that we must always reach out to and study. But you've got to understand the limitations of a textbook. It is a general medicine book. It cannot encompass each and everything of each and every super specialty. So that is why, with regard to certain things, one has to refer to international guidelines, and which keep on updating each day, but each year, I mean. But Harrison, of course, comes once in 3 or 4 years. So there are very many terminologies, very many treatment protocols, which are still not updated, even in the Harrison, which has been released a month ago. So, for that matter, that is why we are here. And that is the reason this residency program has been curated in keeping in mind the needs of all you residents, because we will provide to you all that extra things, the extra edge. And we literally want to, hold your hands throughout your residency and be with you for any, be it a theoretical need, be it a practical need, or for anything for that matter. So definitely, apart from the textbook also, there are a lot of things, guidelines, there are a lot of, you could even learn by watching YouTube videos. I mean, lot of international, for example, in nephrology, KDIGO, there are a lot of worldwide international webinars conducted by KDIGO. So, I have recently resorted to, instead of reading a new topic, or maybe I would easily, at my leisure time, watch that video, because it's an internationally accredited video, of course. You cannot watch any random stuff there. And, I would learn it. So for that matter, you have to keep evolving and keep learning. Thank you very much.
Yeah, I think it's a very important point that Dr. Vivek said. See, when you are a medicine resident, you cannot say that, okay, what is the treatment of myocardial infarction? You just say vague statements and say that, okay, this is what I saw in this book, that book, or what my, coaching center doctor actually taught me. You cannot say that. You have got to quote guidelines. So there are certain scenarios, like say for cardiology, you have the American Heart Association, European Society of Cardiology. So even for a condition like hypertension, you might have different guidelines, AHA, ESC guidelines, the International Society of Hypertension, multiple guidelines. You've got to always stay updated in the guidelines. And what Dr. Vivek was telling, I think it should be a happy news for the, the viewers. We'll just tell you also that we'd like to announce today that we are very soon going to launch a residency program. See, in DocTutorials, we already have, an entrance coaching program that is going on, which is primarily for your NEET SS entrance exam and INISS entrance exam. But we understand that as residents, it's not just about that. For you residents, you want to have the guidelines, the examination stuff, teaching videos. So we are coming up with a residency course. So all of us, the corresponding super specialty faculties, like for example, I'll be taking neurology. And when I take neurology for you, I'll not just be discussing the theory topics alone. Yes, I'll be discussing, but along with that, how to do a proper neurological examination, a proper structured examination. We'll be having videos where we examine in a patient, actual patient, then about the recent guidelines, then about newer drugs, about the newer papers that are being published. And it will be a comprehensive course, which will include case presentations as well. So it will be a 360-degree course. And also, let me tell you, I'll be discussing the approach to common symptoms. This is also very important. You should know how to approach a case of vertigo, how to know whether this is a peripheral vertigo or central vertigo. Similarly, Dr. Vivek also will be having his course structured in a different way. So everybody will be designing their own course. Like for infectious diseases, Dr. Niyasar will be doing endocrinology, Dr. Karthik will be doing. So everyone will be doing in a proper structured way so that all of you will be able to, find residency more easy, because, as far as chilling is concerned, we'll also help you, because definitely this course is going to make your job a lot easier. I think it'll reduce the number of hours that you will have to put to, say, reading of textbooks, and we'll try to consolidate and put everything into one place. So one question that is being asked is regarding pulmonary medicine. The question is asked by Victor Prasanna. Please tell about pulmonary medicine. So pulmonology as a branch, I think we have Nawaz sir, who is a DM pulmonologist in the team. So he will be again coming up with the residency course for pulmonology. So Nawaz sir, just tell us. Salman, the question is, the residency program, will it be helpful for DNB residents? Definitely yes. This will be a 360-degree program, and this is probably the first of its kind where a team of super specialists are doing a residency program. DocTutorials has definitely the DocTutorials has the entrance program, which has been running for some time now, and we are also happy to share that in all the specialties we have got very good results. All definitely credits to our students, and we have been a part of that. So along with that, we are coming up with this residency course. Okay, this will help you in your theory exams as well. So Nawaz sir, your take on the branch, the scope, and how to think of pulmonology as a specialty. Yes, sir.
Thank you, sir. Thank you for the question, and good evening, everybody. So in regards to today's discussion, I think we have a lot of varied discussion about the residency program going on. So pulmonology as such, again, the discussion what we had just before, medicine and pediatrics, similar way, you might be thinking that, okay, pulmonary medicine is an end branch. And sometimes, because we have different pulmonary medicine courses now, like you have got MD pulmonary medicine, and you've got DNB pulmonary medicine and DM pulmonary medicine as well. So it's a little bit more confusing than other branches, because again, we have a diploma also in that. So DTCD. So there are a lot of combinations for pulmonary medicine as such. But what I would again go back to, like sir said, it all depends on your choice of your interest and where your passion lies. So if you cannot separate pulmonary medicine from general medicine, as a pulmonary medicine student, we have to read Harrison and internal medicine as it, because you cannot separate the pulmonary medicine as a specialty. But having said that, okay, this is something which you are interested in, and you have some bit of exposure in your either MBBS days or internship days. It is going to be a different branch and exciting branch, and there are a lot of developments happening. And again, it is not an end branch. So even in pulmonary medicine, you've got now the more of advances and all happening in interventional pulmonology, and there is also sleep medicine, there is also critical care medicine. So it's going to be a combination of all these things. So basically, I think it boils down to what is your passion and what exactly is your expectation and this thing from the field. So
an extension to that same question, I think Satvik has asked,
yes,
what is the difference between MD pulmonology and versus MD medicine followed by DM pulmonology? Partially answered it already, but still again putting it for you.
Yeah, so it's a quite difficult question, because as I said, somehow we have got 4 different courses with almost similar kind of, in terms of, if you look at the curriculum, NMC curriculum, they are going to mention the same kind of textbooks for each and every course. Okay, so the differences lies in, I guess, for somebody with pulmonary MD pulmonary medicine and MD internal medicine, the person with MD internal medicine will obviously be much more confident in dealing with all kind of this thing once you do MD internal medicine and DM pulmonary medicine, because with internal medicine, you would have got extensive exposure to all other systems, which is very crucial. You cannot bypass that. Having said that, okay, you are not able to get MD general medicine, you are getting MD pulmonary medicine. Okay, you can still go ahead with the program, but I think you cannot miss out on learning from, internal medicine and other branches, because at the end of the day, you are going to treat patient as a whole. So that is the major difference. And in DM, of course, you'll have exposure to other stuff. Like I said, you'll have more exposure to sleep, will have more exposure to, advanced interventions. If you are like you person who wants to do a little bit more like surgical kind of work, so interventional pulmonology is quite active these days. So those are the subtle differences what I would suggest. But I still strongly feel that, internal medicine has to be there in your background. If not, you have to be, but at least thorough with Harrison. Even if you are MD pulmonary medicine students, there is no question about that.
Now, next question. Thank you. Thanks a lot, sir, for that inputs. But next question, I think, is a very, very relevant question. See, when you join your medicine residency, right from day one, let me tell you, you've got to have a very rational approach to the use of antibiotics. This is very important because if you don't develop that as a habit, I call it a habit, what will happen is eventually when you pass out, for the first person, you give first antibiotic. For the second person, you feel, okay, I'll give this antibiotic. For third person, let me try something different. So I think we have the best person, Dr. Niyaz, sir. So he has done his DM infectious disease from AIIMS, Delhi. So, sir, what about the importance of a rational use of antibiotics? So how to develop that habit, and also in the residency course, how are you going to deal with this particular topic?
Yeah, this is a topic whose importance cannot be overemphasized, because as residents, like, you will be given this opportunity most often at nights and all. You will be the person who will be deciding the antibiotics. So it's very important. So we all know that like antimicrobial resistance is increasing. You're finding it difficult to treat bacterial infection. It has become resistant to most of our antibiotics. Even colistin resistant organisms are coming up. So it's a responsibility that all of us have to like protect these antibiotics and judiciously use them so that the antimicrobial resistance can be brought up. So that is one important fact. So there is always this, there is a tendency that whenever there's a sick patient comes, irrespective of the diagnosis, we choose to use a higher antibiotic. This, in fact, is not a true practice that we'll be doing. It is not a right practice, because your antibiotics will depend upon your diagnosis. The first thing, if you want to use a correct antibiotic, is diagnosis that you make. So you have a patient who was presented with pneumonia. The first thing that you have to think is it a community acquired pneumonia, or this patient has a risk factor for a drug resistant organisms? That will tell you what kind of an antibiotic you have to use. If you have a risk of drug resistant organism, definitely you can use a higher antibiotic. But if it is not there, even if the patient has like features of a severe community acquired pneumonia, you can still use a third generation cephalosporin, or you may not have to use a carbapenem there. So just to say an example, so basically it depends upon the diagnosis. So that is the importance of making a provisional diagnosis in every case sheet of you. Before you write an antibiotic, you should have a diagnosis on top of that, and also the risk factors for drug-resistant organisms. Then you have a diagnosis, then you can like make an antibiotic choice. Second thing is that you should know your antibiogram, which means that what are the organisms that present to you like in common clinical symptoms. Suppose like you have an outpatient presenting to you like with a urinary tract infection, you should be knowing the antibiogram of the UTI. So what percentage of patients with UTI is resistant to ciprofloxacin in your hospital? Okay. Or the patient develop a catheter associated UTI in your hospital. So what percentage of these patients are actually resistant to third generation cephalosporin? So based upon that, you can choose your empirical antibiotics, because the empiric antibiotics should cover at least 70% of the organism that is addicted. So antibiogram, knowing the antibiogram is also very important. And third step will be, if you know the clinical diagnosis, you know the antibiogram, then you have to choose the correct antibiotic for the patient. So you should know what antibiotic to use. One reference that I can give you from the Indian context is that the AIIMS has brought out an antibiotic policy, which is available as an app. I was also fortunate to be part of the app development. So the antibiotic app by AIIMS is a good tool that you can use from our point of view, but definitely make sure that you tailor or like you adjust it to your hospital antibiotic. So second tool that I would advise is that for correctly using antibiotics, we have another app called a Sanford Guide, SANFORD, Sanford Guide, which was previously available as a book. Now it is available as an app. It is cheap app, like less than 2,000 rupees for a year's subscription. Gives you the correct antibiotics, the correct dosing and renal dose adjustment and everything. I'm not giving like a promotion for that, but that's something that I use. And third will be up to date, which also give you a correct antibiotic dosing and everything, but it's expensive. If your institution has a subscription, well and good. So again, you can use the correct antibiotic. So these are the things that I have want to emphasize regarding antibiotic use. Judicious use is very important. Just because a patient with leptospirosis is sick, you're not going to give him meropenem. So judicious clinical diagnosis is very important. So you can very well treat it with crystalline penicillin. There is no need to use. Okay, doesn't think that it is not in terms of just the antimicrobial resistance at large. It is also detrimental to your patients. If you're giving a third, a broad spectrum antibiotics, the risk of complication that they are going to develop, including opportunistic fungal infection, they're at very high risk. If you're giving meropenem for a long time, they'll develop candidemia. The risk is very high, or a Clostridium difficile diarrhea. These are all complications that can occur. So judicious use of antibiotics is very important. So we make sure that you know about antibiotics properly. As Rahul has already told, we are bringing a residency program, and I definitely will be dealing with antibiotics in detail, of each antibiotics and their uses in detail. So.
Yeah, I am getting a few messages in my WhatsApp as well when the residency program will start. I think in a month we'll be having the launch of the residency program. And I'll just keep you updated. I'll just share the link of the Telegram group of SS in the chat box so that you can join that Telegram group. And also in the Facebook, you have the DocTutorials Facebook page, like you have DocTutorials for SS, you can type. So there is Facebook page. Similarly, you have my Facebook page also. So there is a NEET SS entrance preparation. You can just type and you will have the Facebook page. And I'll just share my number also to you in case you have any further queries also. Definitely the discussion is going on, but I'm just sharing the number 9447 334944. 9447 334944. So these are this is if you have any queries, you can text on my WhatsApp or Telegram. So next question, I think, yes, sir, the same one question for you is from Satwik. So Satwik, I think, is talking of the total DM infectious program. That is a 6-year course. So he's having a confusion in that. Is it true that the DM infectious disease, I think he's referring to the 6-year program, first 3 years you do residency in general medicine and the next 3 years in microbiology? So that is his question.
It's not true. So we have 2 DM courses in India as of now. We have 6-year DM courses, which you can straight away do after your MBBS, and you have your 3-year DM infectious disease program, which you can do after MD medicine in most of the colleges, and microbiology is eligible in the All India institutes. Okay, AIMS, Delhi, Jodhpur, etc. Now, so regarding like the 6-year course, it is not true. Mostly your posting will be in medicine. You are basically under the Department of Medicine. So most of your posting, the posting order, everything will be decided by the Department of Medicine, and usually you will have the posting similar to an MD medicine, except that for around 6 months you will be posted in microbiology. So it will be not 3 years micro plus 3 year medicine, and don't think that infectious disease is medicine plus micro. It's not that. So 6 months you will be posted in microbiology, and you should have a good grasp of microbiology, but you're not going to do procedures in microbiology, but you should know what is happening in the lab. Only then you will be able to interpret the laboratory results correctly. So that is the purpose, and you will be posted in lab. You will get a posting there like around 6 months, but definitely not more than that. But it's not like rest of the time you will be posted in medicine. You will also get the various specialties in medicine also, all cardiology, neurology, nephrology kind of posting also you will get, because you should be knowing this. You should have a basic understanding of general medicine to be an infectious disease specialist. If it is like 3 years infectious diseases program also, you get 6 months of microbiology posting where you have a good exposure to lab. You should be able to do some of the procedures hands-on. It's basic procedures like a gram stain, or a basic procedure like a KOH stain, or a stool AFB stain. We should be able to make, or like a bedside, what do you call as a bedside, like you have a side lab in your hospital, you may be able to do these procedures. So apart from that, it is a purely clinical branch. So mostly you will be doing your rotations in Department of Medicines and allied specialties.
Okay. And again, coming to Dr. Karthik. So Karthik, see, diabetes, almost, it is such an important condition. So I think there are certain endocrine conditions like diabetes, hypothyroidism, hyperthyroidism. So I think any resident is supposed to know in depth. You cannot make excuses that I don't know how to properly manage diabetes, because we have seen often medicine residents not knowing the rationale of choosing which OHA or insulin, what dosage. So what do you have got to say about the endocrine aspects of general medicine residency, and how are you planning your residency course of endocrinology?
Yeah, thank you, Dr. Rahul, for the question. One thing I want to share is that this endocrinology, including diabetes, is one of the most overlooked subject in your residency, because you have long cases and short cases in almost all other systems where you'll discuss even the rare valvular diseases, the rare weird combinations. You will have stroke with very difficult localizations in your difficult final exams, but you hardly ever experience how to manage a common garden variety diabetes. So you often cite Harrison as the Bible of medicine, but I don't think any one of us will be able to treat diabetes in the proper manner just by reading Harrison. So that is one point I would like to highlight. So, and it's how a resident will be able to learn how to treat diabetes, its complications, how to monitor, how to deal with the thyroid problems is actually a 3-year long process. It's from his seniors, from the teachers. So that would be a very gradual process taking such a long time. So what if the patient or what if the resident tried to read these diabetes guidelines by himself? But what I can vouch for, being about to pass out DM endocrinology, I can vouch is that there is no single guideline that will equip you to manage diabetes or thyroid disorders properly. Because the most scientific statements regarding the diabetes management, that is the American Diabetic Association, that just gives you a bird's eye view regarding how you should plan your diabetes management and not regarding the insights of it. So what we are planning in our DocTutorials residency program is that we will be approaching the diabetes in a case-based manner. So we will be giving you what are the scenarios that you are going to likely face, like what is the approach when a patient is first diagnosed with diabetes, whatever mild diabetes. What if he's presenting with a blood glucose of more than 400 with very uncontrolled HbA1c? What if he's first presenting with DKA? Or what if that is a young onset diabetes? What are the possibilities that you like to think of? So what are scenarios that you are likely to face in your clinical practice? We will be having a discussion on each one of these scenarios. And what I'll be concentrating on the residency program is the basic approach. So the most cardinal thing regarding the diabetes as well as the management of any condition whatsoever is to have the right approach. So unless you have the right approach in dealing with these things, you won't be able to make the right diagnosis, and you won't be able to have the treatment offered in the right way. So just like the diabetes, regarding the thyroid disorders also, there is nothing like a drug of choice for hyperthyroidism is Mercosol, but each patient is different. You cannot have a single dosage regimen for all the patients. There are so many nuances in treatment. There are so many conditions which can present with thyrotoxicosis. So unless you have a correct practical approach, you will not be able to deal with the patients in a correct manner. So as I've already mentioned, in our residency program, we'll be having a case-based approach regarding all the possible case scenarios that you are going to encounter in your practice and how to approach them and how to manage and follow up them. So that is about the diabetes and thyroid, and we'll also be dealing about what are the common endocrinological problems apart from diabetes and thyroid regarding adrenal insufficiency and some details on the Cushing syndrome. So how to manage hypopituitarism. So these are some of the things that you hardly ever come across in a correct manner in your medicine residency. So I want to bridge that knowledge gap that endocrinology is still facing in the medicine residency, and I want to bridge that with our DocTutorials residency course.
Exactly, that is the purpose of the residency course. Because see, if you ask me what is the difference between a SS entrance course, yes, we have a specific course for the entrance. where all of us will be taking classes for the, we have lectures, question bank, everything for the SS entrance as well. But this is different. This is to train you into better clinicians. Okay. So as Dr. Karthik said, it will be case-based, how to manage actual scenarios. So I think this course will help you, because what Dr. Karthik is going to teach in endocrine is not just, say, from the textbook of Harrison. See, based on his 3 years of DM training, endocrinology, like the experience that he has amassed, the cases that he has seen, the conferences he has attended, the recent guidelines. So and he'll be giving it to you in a concise form. So the advantage is you will be able to code this, because you are learning endocrinology right from the first day of your residency from an endocrinologist. So I think, it will be an authentic source as well for your knowledge. And, for the entrance, we have a separate program as well. Okay. And I request all the viewers who are watching this, see the questions that we are addressing. I've seen in many, many social media groups, the same questions being asked, how to prepare residency. So please do share with your friends who are going to take up medicine, or who are having confusions, or those who are having similar queries, because this session, I am sure that will be answering most of the queries. So please do share to your batchmates, friends who are planning to take medicine, or they have started taking medicine and maybe they are in first or second year of residency. Okay. Now, a question from Subhash Singh. Sir, this is to Kamal sir. How to approach cardiology in residency? He's asking, I usually get fooled. We have lots of caseloads. I am always fascinated when my seniors make a diagnosis when it comes to me as a JR1, and I'm looking up the stars. So he wants to have a focused approach to cardiology. Sir, what is the advice that you want to give Dr. Subhash Singh on the approach to cardiology during medicine residency?
Yeah, so fantastic question. I think that I would first talk it generally, and then I will talk specifically. Generally, somebody can ask that if you're interested in, say, somebody may be interested in neurology, or somebody may be interested in hematology. And right from the day of first day of residency in MD medicine, if somebody is focused about that specialty, I, for that matter, recommend that you should be adhering to at least start reading that subspecialty also from the syllabus book of that subject, if you are very clear about it. For example, if you're keen into cardiology and then you've made up your mind that you're going to do cardiology as a DM, then at least some important topics like HOCM, like acute myocardial infarction, like ECG, you should be doing from Brunwald's textbook of cardiology, apart from doing from Harrison. Though a lot of chapters are written by the cardiology faculties from Brunwald, they only are the writers of the Harrison's textbook, but that need not be the case for all the subjects. So I think that's one way. Second thing is you should be reading the specialty books, at least from diagram table and flowcharts, because we understand you are short of time and you may not be able to go through the whole of Brunwald, but at least important diagram table flowcharts from Brunwald's in your MD residency, you should try to go through at least for the common topics. Thirdly is the clinical scenario. So you may feel that sometimes auscultation is difficult. The third year, the cardiology fellow comes and he auscultates and tell you this is moderate MS with mild AR, with severe TR, with moderate PH, and you're amazed how could he do that diagnosis. It's all about refining the auscultatory skill, and that's what we are also looking to do in our residency program as we are planning. We are going to take you how to start auscultation. Auscultation is not putting the stethoscope in your earpiece and the bell or the diaphragm on the chest. Auscultation is an art. It was developed by Aubrey and Leatham almost 2 decades back after the discovery of stethoscope. What they called as they call the inching technique of auscultation. And I'll take you through that all demonstration in the clinical lecture series that we do for the residency program. So, and I often say this, that it's not what brand of stethoscope, sometimes rarely a student would come, said, is it mandatory for me to buy Littmann stethoscope? I say it's not the stethoscope that matters. What matters is the brain in between those 2 earpieces. So ultimately you'll have to refine your brain to an auscultatory skill that whatever is the stethoscope, you're able to appreciate that murmur. And for that, there are various techniques like palpating the carotid simultaneously while hearing the murmur,
Even the same is with the ECGs. That's the other example. You know, I mean, I was discussing with the Dr. Rahul, Rajeev, and I was recording my videos on ECG, which are going to be like 5-6 hours. And he said, Dr. Sharma, sir, are you also recording how to take ECG? I know that's the thing. You know, a lot of hospitals in first year would actually make you do the ECG. There'll not be a technician even if he's there. I mean, I don't want to name a couple of states, but that place, those guys are bigger bosses than the HODs. You know, the technicians, they would not do your job, and you will have to plead to them to do your job. So you might have to end up doing ECGs. And if you don't know how to do ECG and your technician has not come up, your staff is not there, I don't think learning in ECG is over just by looking at the strip. So again, we are including that aspect as well. And once you will try to correlate, look at the patient in totality in cardiology. If you've heard a murmur, have you followed up his ECG? Have you looked at echo? Have you looked at his X-ray? Does it correlate? For example, today only in our WhatsApp group, in the Kamal Sharma Elite SS group that we have, I've shared an ECG. The ECG is of a sinus venosus ASD. Now, everybody is jumping onto that because of the crochet sign that it is a secundum ASD. Now, if you know that, and look at the fun, the DM resident has done an echo on this patient because assuming that the secundum ESD is commonest, he's picked it as secundum ESD and missed out of anomalous pulmonary vein. I remember when I was resident, a cardiothoracic surgeon had unfortunately went ahead and closed that ASD, forgetting and not looking at the vein, and this patient ended up in frank pulmonary edema because the anomalous vein was not corrected. So sometimes you don't have to, you know, just, I say that most of the times, most of the things you learn by your 5 senses. And the 6th one is to make sure that you using your 5 senses. Keep your eyes and ear open, and especially in your residency, your mouth shut when you're not asked to speak, especially in front of your seniors. So if you can do that, the residency will teach you a lot of things. Residency not just teach you medicine, it also teaches you life. It also teaches you interpersonal relationship. It also teaches you how you deal with your colleagues. How do you treat your juniors? How do you treat your seniors? How do you interact with human beings? And that, again, when you look at in totality, your crepitations are of failure or with pneumonia in a patient of mitral stenosis is again going to be an important determinant in treating the patient. So try to follow up once you see a patient. X-ray, ECG, auscultation, does it correlate, does the history? And it is said in Perloff's textbook of pediatric cardiology that 90% of the most complex congenital heart disease can be diagnosed simply based on good clinical history, examination, and just X-ray ECG, not even an echocardiography. That is the amount of clinical skill that is required and supposed to be learned. And unfortunately, the art of investigations is ruining the art of examination. But believe me, once the investigation gets flawed, you're in for a soup because you have missed out on the clinical aspect. So make sure that every patient you do and assess in your exam in casualty or ward or OPD, you follow it up right from the auscultation to the point of discharge, and also learn simultaneously the line of management and treatment. So that was in general, and then I thought I'll cover it specifically for cardiology.
Okay. All right. And see, one question I want to ask Vijay sir is candidates who are choosing MD medicine, at least some of them have lesser knowledge of oncology as a branch. Okay. Because when they join medicine residency, they might say, I want to become a cardiologist, neurologist, because their knowledge on the subject oncology is less relatively. So what do you think, sir? What advice you want to give the newly joining residents about oncology as a super specialty?
Hi, students. This is Dr. Vijay, and I am a faculty in DocTutorials for medical oncology. Along with me, another faculty, Dr. Hemant, is also here. So both of us will be sharing our thoughts on medical oncology. Basically, I am from a pediatric background. He is from a medical background. We got interested into medical oncology over our residency period. So I think most of us will find again medical oncology as a rare subject. Only your exposure is going to be hardly for a month or 2 during your residency. And during that time, most of the time, the students will do what their faculty is going to tell them. And gradually they might start liking when they start seeing a leukemia who presents with the tumor lysis or who is bleeding, having some kind of emergency managements. And that is how these when we start developing interest into the subject. But when you really think that is a subject and you want to know or you want to pursue after your MD, either medicine or any allied subjects wherein your medical oncology is an option, actually we can tell you that it becomes more interesting when you know actually what all are options when you do an oncology. You will be into the depths of your statistics, research, the depths of your genetics, and also the ever-changing medical oncology. It's not just a subject wherein you read and start applying. You have to update yourself each and every day, and you see the fascination as you at 4 or hardly 10 years ago, something which was not treatable is now treatable. In another 10 years, it's going to be curable. So this is the rate of change of your subject wherein everything is new, and you start seeing cure as one of the upcoming options. So during your MD residency, it is, yes, you're going to find it difficult to see very less patients and then also treat less. But then when you actually develop interest, see, even when you're doing the limited procedures and you learn the available patients and something like hematology, malignant hematology and those stuff. And when you start developing interest into the subject, it gradually builds on. And when you want to pursue DM medical oncology, we are here again to help you in that perspective. Go to Dr. Hemant as well, his inputs into this.
Extremely valid point. Many institutes do not offer medical oncology as a super specialty posting. To be frank, even when I was there in one of the esteemed medical college, I did my MD from Bangalore Medical Colleges. The posting for oncology was 15 days. And most of my colleagues wanted me to skip that because I would be the only one who would be interested in attending that. So it becomes difficult when you do not have a background. Most of the time, acute leukemia, the management was diagnosis and refer them to Kidwai, call 108. So we'd be the fastest ones to call 108. So that's how the management of acute leukemia at that would be. It is a scary subject. So hence probably medicine is medicine. Sometimes we are not well versed with, but for me, luckily, I had some exposure during my MBBS days where I'd probably see a case of Hodgkin lymphoma, case of germ cell tumor of testis, which probably would have come in extremely sick and get cured just with chemotherapy. So yes, some exposure is important. Most of the time, the most vital super specialties are neurology, cardiology, nephrology. The ones which are probably not are one of them is medical oncology, and ID as a subject is something that is coming up. Why oncology? General medicine, I probably challenge everyone that probably we are the closest here. That is something because we are not organ restricted. Every organ is something. So today I had a patient with myopathy. I had a patient with CKD where I had to plan chemotherapy. I had a past history of CVA. I had one patient with pacemaker where probably I had to consider treating either with radiation or some other drug. So I end up, I need to have at least some basic knowledge of medicine. Not basic, a real good knowledge of medicine before I consider treatment. So that is there. Ever expanding field, cancer is the next big thing. So that is where all the research and interest is going on. If you're interested in research, this is one of the best fields. Lot of scope, especially in the tier 3 cities, the demand is much higher. And in case you want to consider a non-interventional field, right? If in case say somebody doesn't want to do gastro because probably yes, you need to have a setup and you probably need to invest a lot. Medical oncology, you do not need investment, but yes, it is a multidisciplinary team. Sometimes being alone might not be sufficient. You need to have radiation oncologist by close by, or at least a good surgeon you need to have. A lot of discussion goes on with pathology and radiology. These are the fields that we end up discussing, and trust me, cancer is highly curable. We do end up seeing a good number of curable diseases.
Because Satvik is also asking in the comment section Is it true that medical oncology has a very low success rate?
Oh, no. Frankly speaking,
it's not for the faint-hearted. That is what is asked.
Yes, probably it might not be for faint-hearted, but at the same time, I do feel that you need to be an emotional person. Some emotional component is needed. You cannot be emotionally blunt and take up oncology. A lot of emotion is involved in caring. You need to be very compassionate to these patients. They demand that you need a really good care. And most importantly, cure rate. I think after infectious diseases, infections, cancer has the next highest cure rate. CVA, CKD, IHD is not curable, right? So after infections, cancer has got the highest cure rate. This is what my mentor had been telling, and it's actually true. But yes, you end up being a part of their journey. The incidence in cancer is increasing, and you need really good medical oncology, and that is where we are here to help. That we try to bring the best in you, and we try to see that yes, even if you do not have the exposure of oncology during your residency, we be a part of it as per the residency program here.
Okay. One question.
Just on the last point, sir.
Yeah. Yes, sir. Sir.
Any few cases that you see during the residency, do feel free to contact us. That might be the changing point there. Very few cases are needed to drive the interest into oncology, and then your oncology interest opens up.
Yeah, so all of you, please do stay in touch with us through the Telegram groups and the Facebook groups as well. I think the links have been put in the chat box, so everyone will be available and we'll be more than happy to help you. So one question by Saptarshi. Dr. Saptarshi is asking about the toxicity part, whether she wants to go to a different state where there is high toxicity level, but the department is slightly better compared to a college in your state. See, as I said, you all are mature students. You can take decisions for yourself. So always take into account, yes, the college, the academics, everything, but please take into account your mental health as well, because that is important. All you have is one life. So if you feel you're not somebody who can adjust to such level of, so supposedly if there is a toxicity there, take in your college, that's it. Because again, it is you who have to decide for yourself, okay, this is what I want in life. And do not think too much on what others define success for you, which is what I told you before also. Now, coming to one area, which I'm sure many of you would want to know, is the research part during your residency. So I just have Shinto sir, Prashant sir, even Dr. Vivek also, and Kamal sir is also there. So we'll have a few thoughts on the research, the publications during your residency tenure and how to take that forward, research as an interest. So who wants to start off that?
I can start. Should I?
Yes, sir. Yes, sir. Shinto,
yeah.
Sir.
So the earlier in the session, somebody was asking about cure rates. Okay. So who was saying that I would say you should take up that challenge and take that 3% up to 30%. So that's your job. That's what we are doing, right? So say 10, I did my MD say 12 years back. Okay, started my MD. So that time acute leukemia, AML, was said to be like, it is a palliative disease, especially if you are like above 50-year-old patient. Yeah, they are given palliative, some Arasi, sub-Q, and 1 or 2 months they will go around, and after that they are lost. They will somehow hear that they are dead. Today, I am sitting with a patient with AML, 74-year-old, who had passed 3 years of treatment, okay, in remission. So we have newer drugs, right? Hypomethylating agent, venetoclax. So that's how the research is evolving in, especially in oncology, hematology, maybe in other subjects also. So that's what we want. It's all about two lives. Yeah, it's about the patient's life and your life. So how do you balance your life with the patient's life? That's what about all this residency, all your DM, any program, right? So research, when you're talking about research, so research is what made this. So venetoclax didn't come in a day. So it's a baby of years of research, right? It came out in 18. It's one example, right? So today, many of these diseases are curable. You talk about Hodgkin lymphoma, it's curable. ALL, today I counsel one baby, 3.5-year-old. I gave a cure rate of say 90-95%, BALL standard risk, right? APML, yesterday one patient came with consolidation, he's in remission. So I can give him a cure rate of say 85-90%. 90% means 9 out of 10 can be cured, right? So all this came from research. So if I borrow my boss, I was in Vellore, so Vikram Matthews, he researched on arsenic trioxide. So he manufactured it from his local pharmacy, arsenic trioxide, and he is a world expert in APML. So they started using APML from the lab and direct, what you call it, bench to bedside or lab to bedside, whatever you call it. So that made the life different for many a patient. So this cure rate, one thing more is it is not cure for every disease. So you have to be with the patient, even if you are giving a palliative care, be with the patient, be compassionate. So that's all. It's not all about cure. If you can cure him, yes. If you can give him a respectable death, that's also a big part of this training program, I would say. So coming to the research, so say if I'm doing an NGS panel today of 33 genes for an AML today, the AML patient which I have in ICU today, I'm doing a 33 gene panel, which has prognostic implication. So tomorrow, if you people are doing after say 6 years, it will be a 150 gene panel and we have more of targeted therapy. Entirely different. So today we don't treat CLL with chemo. It's all directed ibrutinib. It's a tablet, right? And imatinib, we all know, it is curable. It is imatinib tablet. Nobody does transplant for CML unless it is a blast crisis or something. So 2000, when imatinib came, it was labeled as magic bullet against cancer and Time magazine cover page, right? It is absolutely true. Today, CMLs are like curable, normal life, right? So that all came from research. See, I did my research paper, like in one is in CML. Tyrosine kinase inhibitor. I did IRMA mutations in everybody. So 82 patients. This was one of the largest study. I went on presenting it in Miami, Florida. It's an oral presentation. So research will take you in a different world. It's one thing. It's not all about treating patient, curing patient. It's all about your personal academic career also. You people start to notice you. Everybody here will have their own experiences. Second was Icaros gene mutations in ALL. It was an upcoming topic. It's a newer market, prognostic marker. So I found my own findings were there in Indian population. Okay, so you get to you take your specialty, you learn about your specialty, you give back what you get, right? So you start noticing the new patterns and you give it back. So I would request all the students to take it as a challenge and don't like put it aside like it's only 3%. It's your job to take it to 30. So it's on you, I would say. So please think in that.
Okay.
Just to add on for the toxicity question, it's all hardly 1,000 days or so. This was also told to me by one of my students. So your residency is just for 3 years. So after which, once you are well trained, you can always face your world very well.
Yeah. And anyone else? Nia sir, Prashant sir?
For research, I think there is a very famous saying in West, publish or perish. So either you publish the work that you do or you get perished amongst the others who don't publish. So if you want to be highlighted, recognized, amongst your peers, respected, it is publications of your own work. And for that, all you need to learn, it's not, you can have the other extent of it. You do an innovation, like we developed an algorithm on Apple Watch picking atrial fibrillation, and I was collaborating with one of the Netherlands university, which we just published recently out of my 200 odd publications. But it did not start. I mean, it was not that I came with 100 publication and it has to start from one. And the first publication that I was done was like almost forced upon me. I was first year resident and sildenafil had just come into the market for, the new indication of PH. And all my seniors, my PG teacher would tell, let's look at the 6-minute walk test of this patient, whether it improves or not. And we'll do a study and publish it as an oral paper in a national conference. And then he had told this to the AP told it to the third year told the second year. And ultimately, I was the first year making all the patients walk the corridor and measuring it. I could have taken it as a punishment or the toxicity that we were discussing. And probably it sounded like that only when I was doing it. But at the end of the day, how it translated, just look at the things, how the toxicities, what we think of in a retrospect manner. We ended up, I being the presenter there and then speaking on it. And then when first the trial for Serafin trial came to India, I was the youngest investigator to become from all across India. We had all the big shots, and then I was wondering how could I get it? And they said, because your CV spoke of a research that you had done on pulmonary hypertension. So things you don't know how they come back to you. I mean, I would have never imagined measuring 6-minute walk tests and just counting the footsteps that you do. So the simplest way of doing research, from what Dr. Shinto said, very fantastic, that you can actually go from the bench to the bench or the core lab to the bedside. But there is the other extent. You can start very simple. You can even start to publish or write about the simple or unusual case that you find out. If you find an unusual presentation, say, of a GBS, or say that for matter dilated cardiomyopathy, or Takotsubo is actually presenting at what is called as reverse Takotsubo cardiomyopathy. Those all can be presentable cases, which is an unusual presentation of a usual disease or a usual presentation of an unusual disease. These are the two common presentations that you can make as a case report. And that's from where you start. And for that, to write a research, you will have to read a research. So once you start reading journals, presentations, make presentations from the other research that have been published, look at their methodology, then you will also be inquisitive. And as Dr. Shinto sir said, it's the kick that you'll get out of one publication. That would be the biggest kick that will make you go from 1 to 200.
Absolutely right. Nia sir, any takes on that?
Yes, like almost the same. But only thing is that when you hear about Pareto class and tumor markers, some of you will be thinking like you will not be able to do that kind of research. But research is not just about that. Like, I mean, these are definitely research that we need. Like, we need cutting edge researches, but there are like even smaller clinical profiles that you can study. Simple diseases like leptospirosis, like hepatitis. I mean, we don't have that much of a data about these diseases in India. And we need such data that will help us in making policies and treatment guidelines and everything. So such small topics are also very important. And when you're taking a topic for your thesis, make sure that it is something that can be done in 3 years. Okay. So we'll definitely want to do better research when you are finish your MD, but during your MD time, your thesis should be something very simple. Try to make something that is achievable in 3 years time, without compromising your your duties as well as your your preparation for exams. This has to be something simple. But once you've done that, like definitely.
So I think this is a very valid point sir is telling to all the viewers, because sometimes when you join medicine residency, and you're asked to choose a thesis topic, you would want to, you will have that blood boiling. You want to do the best research in the country. Well, always choose something that is feasible, as sir said. Something in your hospital setup with the resources that you have, with the time frame that you have, like in second year towards the end, you will have to finish. So with the time frame that you have, you should take something, and that should be in a good discussion with the guide on, because sometimes there are certain guides who would insist you, okay, do this topic related to endocrinology, because they might have a special interest in that. But if the thesis guide opens it to you, and then you can just think about what is probably fascinating you at this point. Definitely, you can just come back to us also if it is something related to infectious or neurology, cardiology, nephrology, like that. You can ask the respective faculties. We'll be happy to help you. Yes, sir, please continue.
Same, like exactly what you said. It has to be simple and it has to be finished in that time frame. And definitely, and along that, as Dr. Kamal said, like you can do small works. Like it may not be cutting edge things, like small case publications. It can be small case series of some interesting cases. Definitely, there are plenty of journals if you write it well to get published. And it's all I think. Like once you get published once, and you have that, you have that feeling, you will keep on doing that, and that is how good researchers comes up. And our country needs that, because we have a lot of data. A lot of normal values, a lot of clinical presentations, even are not public. And definitely, you guys can help in that. And any kind of help in that related to research as well, infectious diseases or otherwise, we'll always be there to help.
Yeah, Aniket is asking what is the best source for previous year's question. So if your question is regarding the your MD final exam, most universities will provide it in their website. And in the residency training program, we are also planning to address to this. Some of the important universities, the exam questions, we'll be discussing that, number one. So that will be available as a part of the residency training program as well. If your question is for the entrance aspects, yes, we faculties will be discussing the INISS and NEET SS questions in our platforms. So just stay tuned with us. We'll be discussing all the questions. We all have separate social media platforms where you can interact and solve your queries as well. And even we'll be also very happy if you can share with us, suppose some question, suppose some scenario, a troubling scenario on neurology. Well, you can just ask me. Suppose, if it is something that I also have a doubt, I'll also just back refer and help you, come to a diagnosis. So it's always, learning is a continuous process. It's not that, someone becomes perfect after doing an MD or DM. It's a continuous evolving process. And you've got to accept that humbly. Don't think that every case is a spotter. Remember, when you actually go to see cases in your residency life, patient does not come with 4 options. You have done your exam. The patient does not tell, my disease is either of these 4. You've got to come to a conclusion. There are certain diseases which you can diagnose easily. There are certain diseases you have got to work up. I think that fascination that you have while working up cases, I think is unparalleled. I think Nia sir will remember when I was first year, sir was final year. There was a case admitted in our ward with a fever, long fever of around 3 months, and the patient was worked elsewhere. They did not come to a diagnosis. They thought it is autoimmune. And there was a single but big inguinal lymph node. You remember that case? And finally turned out to be a lymphoma. I still remember every day we were actually perplexed. It was a referral case. It was, I worked up in another tertiary care hospital. It was prolonged fever, but it was just a big inguinal. Big inguinal lymph node was there. And so it's about the time that you spend with the patient. I still remember that particular finding. The patient did not tell us. To be very frank, initially we examined the rest of the lymph nodes. But then only, we just actually looked at the inguinal lymph node and felt. And then only we did a tissue diagnosis, and then it came to a diagnosis of lymphoma. So I think the time you spend.
I remember asking you, how did you find out? Like,
yeah. So I think it is that teamwork that we actually enjoy while in the residency. I think even if you're a first year resident, I think you should trust your abilities, because only then, we all will be able to evolve and become better clinicians. So please remember that. And one very important point I want to tell you is about communication and rapport. So please remember, though you might be a first year resident, you might be frustrated. Please don't translate your frustration to the patient, because it's very important. You will have 1,000 things going around in your head. Tomorrow's presentation, the scoldings and the abuse probably you would have got from your seniors or maybe your faculties, maybe some thesis you have got to find out. But please, when you talk to your patient, don't translate your frustrations to them. Just be calm, be sympathetic and empathetic to them, understand their problems. I think the time you spend with them is important, because I've seen many a times the patients, once they get cured, rather than thanking the consultants, many a times they thank the residents who spend maximum time. Many a times it happens. They sometimes do not know the name of the consultant, but sometimes they come back and say, doctor, you actually treated me. So that is, I think, very, very important. Okay. All right. Any points that others wants to add? Prashant sir, yes?
Sir, I just want to, am I audible?
Yes.
So the previous question on research, I wanted to add. The interest in research can start from even a very small thing. You would not even realize when it happens. Like, I'll give you a small example. When I was in internship, one of a patient was just admitted. She was from West Bengal, was admitted for bilateral pedal edema and hypokalemia. Am I audible?
Yes, sir. Audible now. Yes, sir. Audible now. Audible now.
Am I audible?
Yes, sir. You're audible. Audible. Yes.
But I'm unable to hear my voice. So
you are audible, sir. You are audible.
Am I audible?
Yes, yes, yes.
Okay, sure. So if I'm audible, it's fine. I'm not able to hear my own voice. I'll just go quickly. It was a pure medical case. So in evaluation about hypokalemia and pedal edema, when we evaluated the potassium loss, it was non-renal loss according to algorithm, and there was hypoproteinemia. So we were next thinking, okay, it could be some GI cause, but routine stool tests were negative and other things happened. But clinically, patient on the third day of her admission, we were still questioning why this and that. She actually vomited out a worm. So this was I immediately called up our gastroenterologist who was there and told him, sir, a patient like this was admitted for so and so has been had a worm when she vomited. I'm not sure. So what to do? So he just told immediately come over, get the patient, and we did an endoscopy. From the duodenum onward, it was full studded with different kinds of flukes, and then it was fasciola intestinalis, and then the patient also had other different type of worm fully studying the entire colon in the colonoscopy also. And then from there on, it moved as a case report, the first one of that form, where we reported it as a parasitic zoo of multiple types of different kinds of parasites. We had a fasciala intestinalis and gastrodiscoides hominis in the same patient, and also later the stool report came positive for two other smaller infections like entamoeba and other things. So a patient had multiple organism coming up in the same patient. So this was my first case report, and incidentally it was in gastroenterology. And then the consultant who gave me the thing, he pushed me to present and to publish it in he was pushing me so much, because at MBBS level to push so much, I liked the concept of how that then I got two other offers or three other people approaching me based on that single paper. And then incidentally again, the consultant who trained me then when I was doing my MBBS was again from CMC Vellore. Then the vision started. Yes, I have to study and have to get there, and I have to get the branch also. It was just deep inside, but I was never sure if I was ever going to make it there. But it was a journey which started at an internship and then went on to do MD, then went on to get the same place, and then to become an alumnus there. We meet again. So then comes how we contribute. During my DM phase, I really learned what is ethical work, because sometimes when we do a research and we were unable to complete the entire thesis during the MB period, there are phases where we are sometimes even our MD course may get prolonged, or if the we may try to manipulate and somehow get the results out because we just want to get the next step. All this happen. So these are ethical questions which gets clear that being truthful and honesty really pays a lot. These are some of the things which we learn in due course. Then during DM, when we started doing, my interests on these studies of the making research and simple topics improved, and despite being a tough place to work with, initial first year we would not even be able to think, but still there were almost 4 to 5 studies I were able to do just during the DM phase because of the sheer interest. You have interest, consultants are there to give you some ideas, ethical work, hard work, and you'll be able to do a lot of work. Initially it started as a single thesis topic, but parallelly there were 4 to 5 studies. In my DM phase, I got a first chance to go outside India in my final year to present in APASL at Philippines, at Manila. So again, see where all it can just get you in. And then when I completed there, again, even now I am into the topic of plasmapheresis in liver disease, which plays a major role. Now I am in a smaller setup. Like, just to give you an example, here we have done the first plasmapheresis of the city in Radol poisoning, and we have saved 2 patients from impending liver failure. So these patients would have definitely got liver transplant, and there would have been a bridge. We have saved these patients. There were 2 patients who presented to me with a different case. One patient presented to me in Bangalore, and my friend called me up, and we tried to manage the patient, and a similar patient came here, and both of them had recurrent hypoglycemia, and it was an adult onset nesidioblastosis which we have treated. So these 2, again, I'm planning to make it as a case report. So the exposure is lifelong. It just goes on and on and on. So research means it depends on your place, where you are from, and your interest. Both should sync, and you would be able to do amazing work. Now I'm in a peripheral setup. I'm doing case reports, interesting cases, may not be able to get the big numbers. So research is a lifelong thing, and learning goes on. And I think that's really, really important, that if you're interested in research, anywhere and everywhere, you would be able to contribute in some or the other form. Second question was there, but because I'm unable to hear any of your talk, I'm unable to, get back to you guys. I think I'll log in again. If the talk is still going on, I'll get back to all of you, because I'm unable to hear any discussion going on. Thank you.
All right. One point I want to put for everyone is that, hello, am I audible? Okay. All right. So one point I want to put forward is that when you write your orders in medicine residency, please do not write welcome drinks or cocktail regimens. Welcome drink means often it happens, patient comes with headache and you write injection pantoprazole. Pantoprazole has nothing to do with your headache. So I think rationally using the drugs, whatever it be, Nia sir was talking about antibiotics, but it's important that for any condition, you try to minimize the number of drugs. As they say, drugs are not, the food. So it should not be like you write pantoprazole for every case that you see, because even in NEJM in 2017, there was a paper that was discussing on the irrational use of the proton pump inhibitors. So that is something you have got to be careful about. When you write your orders, at least you must be aware of why you are writing it for, and also keep in mind the adverse effects as well of the drug. And whenever you are taking a case during your residency, always remember, try to see it as a whole patient rather than a system. Even if it is a myocardial infarction, the patient might have had an anemia, which would have precipitated the anginal episode. So it's important for you to have a look at the hemoglobin as well, rather than just thinking, okay, I'm going to just treat the myocardial infarction. So seeing the case in totality is very, very important. Now to the faculties, if you want to, I think we have taken majority of the queries, but if you want to say some other points related to this, please, you're free to.
For nephrology, sir, I would just like to, mention this, that very often I see medicine residents, my juniors, say, for example, when they are correcting a simple case of hyponatremia, everybody works at a very spinal level and they know that the sodium is low. So, you can just add salt tablets, or they add 3% hypertonic saline and whatsoever. But you've got to, when you are a medicine resident, it is very, very important for you to have a very rational and structured approach to each and every disease. Once you develop that, you have to stand out against a person who is not trained in internal medicine. So for that, you must have an algorithmic structured approach in whatever you manage. If you're managing a simple case of hyponatremia, say if you are interpreting a simple urine routine report, if you do not know what is normal, how many RBCs per high power field is normal in a adult urine, how would you know what is abnormal? So that is the way we are planning to bring up this course. And in nephrology, again, I am planning to include more of live examples. I'm planning to give you more real life scenarios. The patients that are currently admitted with us, the case scenario, the sodium level, the potassium level, the creatinine, how would I interpret them? How would I correct them? How would I calculate the sodium deficit? How will I, first classify it at whether is it true hyponatremia or not? That is the approach that we're looking at as. Of course, we'll be dealing with the theoretical part, but the practical aspect of it, I mean, when you see a report, what do you infer out of it? What is the important thing that you have to examine? Because we all have been studying that, yes, you divide hyponatremia as euvolemic, hypovolemic, hypervolemic, but how do you actually do that? And how do you approach a case is very, very important. So, you know, this vertical and horizontal integration is what we are trying to bring in this course.
Yeah, so it will be a 360-degree course, as Dr. Vivek said, covering theory lectures, examination parts, actual case scenarios, case presentations, okay, help for your theory exams, discussions. So everything will be covered and everything will be taken by the corresponding super specialty faculty, and it will be a fun learning. You know, we all are not so serious people, so it'll be a fun learning. Like Vivek will be bringing out case scenarios and it'll be an interactive one. And if you want to ask him a question based on that, why not think about this differential? You can just be in touch with him. He'll definitely tell you and guide you. So I think this course is definitely going to be a game changer course where you will have an entirely different perspective learning from all of us. So any other last words anyone wants to join? Okay, all right. So I think we have taken majority of the queries of the students. I'm sure yet some people will be joining a bit late. Maybe you will be seeing this in YouTube. Again, I request all of you to please share it. And why I say this specifically is because I'm seeing in social media, so many students are getting confused by people who actually confuse others, saying about medicine branch, confusing them, saying no scope, saturation. Let me tell you, this word saturation is actually, I call it a misnomer, because see, it all depends on the place where you want to work, whether it is in a corporate setup or in a district or wherever it is. So it's not like some branch is saturated or not. Then you can say for any branch there is saturation, but it again depends on the place where you want to work. So please, when you take your guidance, choose it from the right people. Do not just see a random post in Facebook and say that, and that might often be a fake profile with a peculiar name also, and trying to confuse others. Probably they want to decrease the competition of joining their branch. So please come back to us. Again, any doubts, you can text me in WhatsApp and Telegram 9447 334944, and you can be in touch with all of us. Any doubts, we'll be happy to help you. Any further queries, you can type in the, like when it goes to YouTube, okay, so the comment section will be open, and you can actually ask the doubts, and we'll be replying in the comment section of this YouTube video. So thanks a lot everyone for joining, especially all the faculties. We all are actually enthusiastic to talk to you. Very, very happy to talk to you, because this is a very important turning point of your career, and I think definitely we'll be a part of it, and we like to be a part of your further progress as well, because obviously we all will be colleagues, and will definitely be a pleasure to meet you all in some conference as well. So thank you to all the faculties for joining, and also for the students for listening, and stay tuned to the DocTutorials social media, and where we will be guiding you further during your residency. Thank you, everyone. Bye-bye. Good night.
Bye-bye.
Good night,
Thank you,
everyone.
sir. Thank you.
Good night. Good night.